Welcome to Diabetes Day by Day, the American Diabetes Association's official podcast. It is hard to believe that we're already here in 2025. Hope the year has started well for all of our listeners. For all of us in the diabetes world, the beginning of the year represents many things. Of course, it represents the time to refocus on what's important, and it represents the opportunity to move forward with a new attitude and renewed enthusiasm and vigor for getting things right or trying to again. But the other thing that it represents for us is an opportunity to update on what the latest recommendations are that are issued every year by the American Diabetes Association through something called the Standards of Care in Diabetes. Every single year, the American Diabetes Association picks an elite group of clinicians to get together and review all of the evidence that has come out in the interim from when the standards were published the year before. And this group, and it is really an amazing process. This group doesn't just say, hey, let's recommend this. No, they look carefully at the evidence. Then they debate what has the best evidence, what is worthwhile to include in the standards to make the changes that the rest of us throughout the country then try to implement. And it's not always straightforward and it's not always easy, but it's always done with a lot of care and one thing in mind, with the best, to provide the best recommendations based on the best evidence available for people with diabetes. Today, Sara and I are going to do our best to highlight some of the most important takeaway points from the standards of care. I'm Dr. Neil Skolnik, professor of family and community medicine in the Sidney Kimmel Medical College of Thomas Jefferson University. And Sara, this is a good time, as always, to introduce yourself.
Thanks, Neil. Happy New Year to all of our listeners and to you, Neil. I celebrate the new year in such a wonderful fashion in my own life, but also celebrate the release of these standards every year. I'm Dr. Sara Wettergreen, an assistant professor at the University of Colorado Skaggs School of Pharmacy and an ambulatory care clinical pharmacist. And thinking about the standards of care, I reflect on my own clinical practice today, where I was sitting down with a patient, talking through adjustments to diabetes medication regimens, and actually reference the standards of care. It's something that some listeners may have heard of, some may have not. But since it is an extensive document and there are so many recommendations in that document, we wanted to spend some time today to highlight a few key points. We certainly can't get to everything in our 30-ish minute session today, but want to take the time to highlight at least a few key points that listeners can take with them and reflect on. Am I meeting this goal? Is this something that might apply to me? And if so, how do I bring that up with my provider?
And Sara, it's fascinating, as you say, that today you were sitting down with a patient and referencing the standards of care. And we are recording this on January 7th. It is 7 days into the new year, and you've already gone through that 350-page document, and you are right up to date. But I also want to remind our people who are listening that it is hard for your doctor, your PA, pharmacist, nurse practitioner, keep up with all these changes in every different area that we take care of. So please don't think less of someone if they haven't, by the 7th of the month, gone through all of the standards. And don't be afraid to bring up respectfully if there's new information that we share, to say, hey, I listened to this podcast from the American Diabetes Association, and they said there's a new recommendation out there. What do you think of this? And to ask the clinician that you're working with, what do you think of this, is a good way to nicely prompt someone to move forward and address whether or not the recommendation fits you as an individual. Sara, let's start off with really where things often start off with, which is screening. Now, we know for years there has been a recommendation to screen for type 2 diabetes, essentially, for everyone over 35 years of age and in individuals who have overweight or obesity, regardless of age. But there hasn't until this year been a recommendation for screening early with autoantibodies for pre-symptomatic type 1 diabetes. And this year, there is a new recommendation that for people who have a family history of type 1 diabetes, that autoantibody-based screening for pre-symptomatic type 1 diabetes should be offered. Now, let me just inform everyone why this new recommendation came out. And it turns out that a lot of people with type 1 diabetes don't know they have it until they present really quite ill. We actually had a podcast about a year ago with a doctor whose daughter has type 1 diabetes who presented quite sick. It turns out that there is a way to detect type 1 early, and the people who have the higher likelihood of having type 1 are those who are family members of someone who already has type 1 diabetes. And the best way to screen isn't with a blood sugar, because early on that blood sugar isn't yet elevated, but with something called autoantibodies. Autoantibodies to different parts of the pancreas appear early in that pre-symptomatic stage. Now, we've known this for years, but now there's a medicine, and there are other medicines in development that are available to delay the progression from a pre-symptomatic phase to full-blown type 1. So given that, there are now recommendations for screening with autoantibodies. Don't ask what autoantibodies are or their names. Just mention it to your doctor. They'll figure the rest out. Sara, I know that diabetes technology is something that you use all the time in your clinical practice. You're in an endocrinology clinic. We're all using technology more and more. Can you share some of the updated recommendations regarding diabetes technology use?
Certainly. And you're exactly right, Neil. I think technology is something that's only growing in the diabetes space. It's becoming more common in many different practice areas. So not just specialty clinics like where I work in endocrinology, but primary care settings. Many people are using technology. And I would say that the standards of care recommendations align with that. We see the recommendations regarding diabetes technology are heading toward earlier use and using more often. Thinking of that, there's a recommendation for early initiation of technology, and this can be considered as early as the time of diagnosis. And this not only includes continuous glucose monitoring, but also insulin delivery systems. So while that is something that's recommended, it is all individualized and patient specific. And so it's something to think about in terms of the level of technology preparedness that an individual has. But it's good to know technology is recommended almost at any stage of the management of diabetes. There were also some specific updated recommendations related to who should use certain technologies, for example, to continuous glucose monitoring. So with that, it's recommended that either real time, meaning continuous data is coming, or intermittently scanned continuous glucose monitoring, where a device is scanned with a reader or a cell phone to collect that information periodically. Either of those can be used for diabetes management for either youth or adults who are using insulin therapy to treat their diabetes. So a pretty broad recommendation, and that may open up doors for more people to have access to that technology who are using any type of insulin. Right now, some insurance companies might require multiple injections per day, and this recommendation really says any type of insulin, whether that be 1 injection a day, 4 injections a day, still recommended. There was also a recommendation change that I think will be influential to practice related to considering the use of either real-time or intermittently scanned continuous glucose monitors in adults with type 2 diabetes, whether or not they're taking insulin. So even people who are not using insulin within their medication regimen. I think this is important because in practice right now, as I alluded to, coverage sometimes is based on insulin use. And so this recommendation may be something that can change practice and expand coverage for those who are not using insulin, but may benefit from use. And this recommendation is based on emerging evidence and really highlights the benefits that can be seen from using continuous glucose monitors in people with type 2 diabetes not using insulin to help achieve and maintain their individualized glycemic goals. Neil, what are your
Sarah,
thoughts
I,
on this?
I I loved that recommendation. I was so excited to see it because I think that those of us who are in practice have learned through experience about the benefits of CGM for our patients. The data had to catch up with what we've actually learned boots on the ground, that when people put a monitor on, they pay more attention, they notice, their curiosity leads them to notice how what they eat, what they do influences their blood sugars. And without changing any medicines, people's blood sugars often improve. And it turns out the literature caught up and showed that they improve about the same amount as adding a whole nother medicine on. So I was just really thrilled to see this because it supports what many of us have come to be doing.
Exactly. And I feel like sometimes it's our single person results that we see and we see the benefits in. And it's helpful to know that large scale studies are showing similar outcomes because that's what's really going to change practice. Now, next up, Neil, let's talk about weight management. There are some common questions that I feel are answered by these updated recommendations. Neil, do you want to expand and share?
Oh, yeah. This has become such an important area. And I just think back, I think it was 2 years ago when the standards of care changed dramatically to include weight management on par with glucose management when we approach the treatment of people with diabetes. And now, as we move ahead and have gained more experience, a couple of new things that were mentioned in the standards. One is the concept of what to do once you've achieved your weight goals. So your sugar goals are achieved, you've lost the weight. Do you stop the medicine now? To ask that, I think you begin to already guess the answer. And it turns out that if you just suddenly stop the medicine, usually a GLP-1 or a dual GIP GLP-1 receptor agonist, if you just stop the medicine, most people will begin to regain their weight. And again, I recognize that blood sugar control goes along with that. So the recommendation is actually that weight management pharmacotherapy is indicated for chronic therapy and should be continued beyond reaching the weight loss goals, but it gets more nuanced. And this is where I think there really has to be close working together between people with diabetes and the clinician taking care of them, because it's not always clear that the same current dose that got you to where you are in terms of weight loss needs to be used. And this is where that idea of shared decision making, us talking with our patient, do we continue the same dose? Do we wean it down slowly to the lowest dose? Is it able to be weaned completely off? Because if someone has lost weight, their sugar control might be as good, even not on the same amount of medicine. And you can figure that out as you go. So a lot of choices that require really close working together between a clinician and the person with diabetes. That's one. The other thing that has come to light as we've used these highly effective weight loss medicines more is that some people, and this is not most people, but some people can actually get protein calorie malnutrition. When they lose a lot of weight quickly, if you're not paying attention to, you can end up really having a deficit in terms of nutrition. So what do we do about that? One, we want to, again, work closely together and want to make sure we have enough protein in our diet when we're on these highly effective weight loss medicines, and want to make sure we're doing enough exercise. That should be not just aerobic exercise, but also resistance training. What's resistance training? Either those bands or light weights. You don't have to be working out in a gym with big weights, but enough so that your muscles are getting a bit of push and growth and paying attention to enough protein intake. So those are the main things to narrow down about what's new in weight loss that we can pay attention to. Sarah?
Yeah, when thinking about these, I think they answer some very common questions. And one thing that in my pharmacist brain really stands out is thinking about how much a team-based care approach can be helpful for these, whether it be the medication management and working closely with your physician provider, advanced practice provider, pharmacist, and then thinking about the nutrition piece, working with dietitian or certified diabetes care and education specialist who has that expertise. I think sometimes we have this tendency to think it's very simple and you start the medication and that's it. But I think there is this benefit to this team-based approach that we see here.
There sure is. It's so important. Now let's move on. You mentioned medicines. Let's now talk a little bit about, there's always evolution of care with regard to recommendations for which medicine, for which person. Anything stand out for you, Sarah, in the updated standards of care?
Gosh, Neil, there are always so many updates to this section. I think it's one of the, I would say, heftier sections and sections that a lot of us clinicians go to and really dive deep into. And so I would say a lot of that language is more provider oriented. And so today I really want to focus on those that I think are most important for people living with diabetes or caregivers to know about. So thinking about that, in recent years, we know there's been a ton of evidence come out regarding the benefits of using certain medications called GLP-1 receptor agonist or an SGLT2 inhibitors, things we've talked about on our podcast before, for reasons beyond glucose. This can be reducing risk of cardiovascular conditions and kidney disease, as well as things like weight loss. In addition, a new recommendation was added to the standards this year stating that for adults with type 2 diabetes and a specific type of heart failure called preserved ejection fraction, as well as obesity, a GLP-1 receptor agonist with benefits for glucose and heart failure symptoms is recommended. This is important because the previous standards recommended only a certain medication called an SGLT2 inhibitor that can be used for both glycemic management and prevention of heart failure hospitalizations. Regardless of the glucose piece, we now have an additional option. So I think it's important to know that you have multiple medication options who are showing benefit in these specific heart conditions. And so if you are someone who has heart failure, even if you're not sure which type, it may be worth bringing up this with your provider to make sure the right medications have been considered for you or something that you've talked about or maybe are using that have this additional benefit and evidence. Another recommendation was updated to state that in adults with type 2 diabetes with chronic kidney disease, a SGLT2 inhibitor or a GLP-1 receptor agonist, so again, both medications, with demonstrated benefit in this population should be used for both glucose management as well as for slowing the progression of kidney disease and reducing the risk of cardiovascular events. So basically saying that for both of these classes, there are numerous benefits beyond the glucose picture, whether that be related to kidney function, heart failure with preserved ejection fraction. We already knew about cardiovascular risk reduction. So this is really intended to capture the numerous clinical trials that have showed benefit in a variety of populations. And so it would be just worth bringing up the medications that we've talked about today to see if they may be options depending on your risk and your individualized factors. Do you have any comments, Neil?
I think that it's an interesting area, Sarah. You and I focus on the really important new changes, which really are around the GLP-1s in both heart failure with preserved ejection fraction and the new data on the benefit of GLP-1s for people with chronic kidney disease. I think when we look at the large world out there, the learning point for our listeners is that if you have any type of heart failure, or if you have chronic kidney disease, ask about SGLT2s and GLP-1s and where they fit in, because both classes are underutilized and are incredibly important in slowing progression of chronic kidney disease, in slowing the progression from mild to moderate to severe, even to dialysis, and in decreasing cardiovascular events in people with chronic kidney disease, and with heart failure, decreasing hospitalizations, making you feel better, which is, of course, very important. And the take-home point for our listeners is, if you have one of those conditions, heart failure or chronic kidney disease, ask your provider about these two classes of medicines and if one or the other is right for you. Sarah, back to you.
Thanks, Neil. Yeah, I appreciate that addition. I think it's just so helpful to put all this information into context since there are so many recommendations here. Another topic that was added to the medications section specifically of the standards addressed a key question. And are these compounded products that we see on the media? I feel like I can't go on the internet without seeing advertisements for them or on my TV. Are these recommended? So there's a new recommendation from the Standards of Care that addresses this that states the use of compounded products that are not approved by the FDA is not recommended due to uncertainty about their content and resulting concerns about safety, quality, and effectiveness. We know from clinical practice that there at times have been some concerns about the safety and effectiveness of compounded medications that are not FDA approved. And so looking at that, the statements make it clear that they're recommending to use the FDA products and then also applying that information in case of shortages. So if there is a medication shortage, wanting to switch between different FDA-approved products rather than going to unapproved products. Neil, is this something you've seen in your practice?
Sarah, we have, and I just want to let our listeners know, literally a week and a half ago on the podcast that is oriented toward professionals called Diabetes Core Update, we had a special edition on compounded medicines. The short summary is this podcast talks about the incredible carefulness that goes into traditional manufacturing by large pharmaceutical manufacturers and some of the scary lack of quality control in the compounded medicines. So it's something that I was very happy to see that this was included in the standards of care. Let me mention one other thing that is now in the standards with regard to thinking about treatment medicines, which is MASH, metabolic associated steatohepatitis, very complicated sounding name. People might have heard of it as NASH, non-alcoholic steatohepatitis, or people may have heard of it with its common name, fatty liver. No matter what you call it, the liver can get filled with fat. Fat can cause inflammation, and inflammation can cause fibrosis and eventually can lead to liver failure. About 60% of people with diabetes and obesity also have metabolic associated liver disease, fatty infiltration of the liver. I don't want to spend the time right now going over the different potential treatments for it, other than to say a few years ago there wasn't a whole lot to offer. Now there is. It is worth asking your provider about whether or not they should look into whether or not you have fatty liver, and if so, whether treatment would be helpful. The other thing that I was, as always, thrilled to see physical activity mentioned as a focus in the standards. Now, the fact that we should be exercising should not be news to anybody. This has been in the standards for a long time. So we've known for a long time that we want to try to achieve 150 minutes a week of aerobic activity. That's about 30 minutes a day. If we can't do that, let's just try to do 10 or 15 minutes a day, right? 150 minutes to 300 is our aspirational goal. What's new this year, and is consistent with the World Health Association recommendation, is to limit sedentary time. And the recommendation very specifically is to try to avoid prolonged sitting. And if you need to for work or for whatever reason, get up every 30 minutes for about 5 minutes. And it's pretty amazing. Just 5 minutes of standing, stretching, taking a walk for 5 minutes, then sitting back down to work actually improves blood glucose control all day long. Now remember, this isn't just when you're at work, but they also recommend paying attention to recreational screen time, which of course has become an issue not just for adults, but also for adolescents and kids. Sarah, any thoughts there before we move on to talking about nutrition?
Neil, you're just making me think of my recent movie experience watching the movie Wicked, which is nearly 3 hours in length. And I don't believe I stood up sufficient number of times during that movie. And so I think it's important that the standards are calling out this recreational screen time. Might be hard to do that in a theater and get up and walk around and miss key parts of the movie, but think about those times when you can work that in at home or break up your work day or those recreational times when you are watching movies and things.
Nice. Let's go on now, Sarah, and talk about some of the recommendations for nutrition.
Absolutely. So, when thinking about nutrition and reflecting on the standards, I really felt like a lot of the points covered in the standards were very similar to topics we've talked about on this podcast previously. So, we won't harp on them too much. But for example, there's no particular eating pattern that's recommended, but rather the focus is on key nutrition principles. Things like inclusion of non-starchy vegetables, whole fruits, legumes, lean proteins, whole grains, nuts and seeds, low-fat dairy or non-dairy alternatives. When I hear that list, I think of the numerous different foods and combinations I can make with that. In addition, it's recommended to minimize consumption of some of the things that we can think of that maybe not as beneficial for nutritional value. Things like red meat, sugar sweetened beverages, sweets, refined grains, processed and ultra processed foods, which was newer to be addressed in the standards in people with both prediabetes and diabetes. And I would go to say most people would probably benefit from eating in those types of patterns. There was another new recommendation suggesting to drink more water rather than nutritive and non-nutritive sweetened beverages. I think a lot of people could benefit from that too, as I think about my own water intake today. And then looking at recommendations for people with diabetes and those at risk for diabetes to incorporate more plant-based protein sources. Again, these are things that were mentioned previously, but things like nuts, seeds, legumes, and having this be part of an overall diverse eating pattern to reduce cardiovascular disease risk. We know that one eating pattern or one meal type doesn't fit all, but it gives us some of these key principles to think about. And the last one I want to mention is limiting intake of foods high in saturated fat. This is again the red meats, full fat dairy, butters, coconut oils. I'm going to throw like ice cream in there in that full fat dairy piece. And these are also recommended in limitation to help reduce the risk of cardiovascular disease. Neil, what are your thoughts?
I think it's both important and also gets really hard to carry out is the truth. I love the fact they said there's not one clear best eating pattern because there are a lot of patterns that work. But if you take just what you said, Sarah, as a guide and you really implement it, 80% of us will be eating a lot better than we currently are. And I think that's the thing here, that one, to remember the things that you just went over, and two, to learn to read food labels, because there is a lot of information in food labels that can direct us toward more whole grain products, can direct us away from things that might contain a lot of salt. For instance, regular white bread is one of the most common sources of salt. Wouldn't normally even know that unless you look at the label. And it is a critically important part about care of ourselves, whether or not we have diabetes. And it's a part that we often don't pay as much attention to as we should. Yeah.
Right. When I think about these recommendations, it's something you've probably heard before. I know we've talked about the implementation day to day can be a challenge. Now, Neil,
Yeah.
we've covered so many updates from the standards of care in diabetes for 2025 today. The next step I'm thinking about is what do listeners do with this information? Neil, you shared a bit at the beginning from your perspective as a primary care physician. What would you recommend for this person living with diabetes or a caregiver who's listening today and they want to bring up these topics with their provider?
I think this is the critical question of this episode, Sarah, because our goal of this podcast is to empower people with knowledge, not so that they just know something, but that they can use that knowledge for the benefit of their health. And in order to do that, frankly, takes a little bit of finesse and sensitivity to others. Remember, the person taking care of you as a professional is also sensitive as a person. And if you bring up something by saying something like, hey, didn't you know that American Diabetes just said they might not feel as good as if you say, and I love the idea of saying, I listened to a podcast where they went over the newest information from the standards of care, and they mentioned that, for instance, an SGLT2 might be a good idea for me since I noticed on my portal that I have chronic kidney disease. What do you think of that for me? And that allows your provider to hear what you're saying in a non-threatening way, know where you got the information from, that it's from a credible source, not from some unknown site on the internet where, believe me, as providers, we hear that sort of thing far too often. I saw something on the internet and they said, do this. And we're ready before we even hear what we're saying. I don't know about that. So you heard it from a credible source, the American Diabetes Association's podcast. And the other thing is, what do you think of how this applies to me? Because what we have such good training in is how to take all of this evidence and recommendations and apply it to you as an individual, because it is never one size fits all. So that way you get the best of all worlds. You hear the latest of information and you hear from your provider how to apply that to you as an individual. Sara, your thoughts?
I agree with those points, Neil. I think it might feel uncomfortable to think about those points or try to remember the right order of the letters of SGLT2. But if you get close, I know they're going to know what you're talking about. So I would say I would just encourage our listeners to be your own advocate and to bring up these points with your medical team. And one of the things that I think is important around that is to have that appointment. I think too often we see individuals who maybe don't have routine follow-up, and so they miss the opportunities in that year to think about how these new recommendations might apply to their care. So start off by making that appointment. Sometimes it's hard to do, but I encourage you to do it. But then also think about recommendations we've talked about today that you can implement right away. Things like drinking water over other beverages instead of sugar sweetened or non-nutritive sweetened beverages. What can you change in terms of your eating pattern? Can you interrupt those periods of prolonged sitting? I think these are things you could do immediately or try as soon as you would feel comfortable doing so, while also taking that proactive step to discuss with your medical team.
Sara, thanks so much for wrapping things up like that, because I think this has been such an excellent podcast where we've covered so much ground. And of course, to our audience, thank you, as always, for joining us. Tune in next month for our episode that we're going to call There's an App for That, where we'll review some of the most commonly used apps in the diabetes space. If there's a diabetes app that you find particularly helpful, please let us know and we'll try to include it in the next episode. Just leave a message at 703 755 7288. Again, that's 703 755 7288 with any suggestions you have, and we'll do our best to include those suggestions. For the American Diabetes Association, I'm Dr. Neil Skolnik. Thanks for listening.